Hello and welcome to another episode of the Health Notebook. Today we're discussing palliative care and we have Dr. Cupido in the studio. Dr. Cupido, welcome.
Thank you very much and thank you for having me on your show.
Dr. Cupido, just tell us a little bit about yourself.
So I'm a general physician. I work in one of the state hospitals in Wynberg and I have a passion for teaching. And over the last 7 years, I've actually become very interested in palliative care, and I've been working in that area of palliative care as a subspecialty, but it's part of my daily work.
Okay. And when you say subspecialty, you also a specialist, eh?
So I am first you become a GP, and then I've specialized, become a specialist physician.
Okay.
And palliative care, in South Africa, there is no speciality of palliative care. One can do a diploma in palliative care, as in postgraduate diploma, but currently palliative care is not considered a speciality in South Africa.
Okay, so you probably studied around about 10 to 12 years, correct?
That's correct.
Okay, so let's get on to today's topic, and it's palliative care. What is palliative care?
Right, so palliative care essentially is it's more or less an approach to healthcare, but it involves more of a holistic approach. So we look not only at the disease that the patient has, but we see the patient as a person who has a psychosocial side to them. They come from a family, and so palliative care involves looking at the family dynamics as well as the impact that the disease has on the family. And it really involves caring for patients who are extremely ill. And our first attempt is to make an impeccable assessment of what the diagnosis is, and then to manage the patient's symptoms of the disease and not focus exactly on the disease.
Okay, you've mentioned when you make a diagnosis and terminally ill. So what are you referring to? Are you referring to patients that have cancer or patients that have certain types of chronic illnesses? In what frame, or just give the viewers a little bit more insight pertaining to that when you speak about terminally ill patients?
Right, so essentially once we are born, we are going to die.
Okay.
And so every human being is at some point in their life going to die, and any disease process can lead to that point. However, everybody would believe that the commonest cause of death is cancer, and the reason for that is that cancer is very well aired in the media as the commonest cause of suffering, and often that suffering is considered to be pain. So these days you can grow a moustache for cancer, you can wear pink, you can cycle, run, you can even run in a Speedo for cancer. And so everybody believes that cancer is the disease that leads to a terminal illness. However, heart disease, lung disease, kidney disease, brain disease, all of these conditions can lead to death. And in South Africa, and in fact this point in Cape Town and the Western Cape, the commonest form and cause for death is actually cardiovascular disease.
Okay, so what you're actually saying is that there is the normal tendency to associate palliative care with cancer, but palliative care can also be provided to those chronic illnesses such as heart failure and other illnesses. So do we provide palliative care towards the end of the disease, or where does palliative care come in?
Right, so as I was saying, it's an approach to healthcare, and essentially we believe that palliative care really starts at the beginning. So when a diagnosis is actually made, for example, a patient is diagnosed with diabetes, and they may well be 45 years old at the time. They're diagnosed with diabetes, and at that point they don't believe that diabetes is going to lead to their death. But 10, 15 years down the line, diabetes is going to lead to the complications, which may be a stroke, maybe a heart attack, maybe kidney failure, and that would then lead to the death. So early in the diagnosis of a disease, one would consider that we would like the patient to be aware that if the disease is not well treated and well controlled, it will lead to complications. So initially, there will be 99% of the care and management would be medical management. In other words, pure medication and advice around diet and lifestyle changes. And 1% of the management would be devoted to palliative care. And as the disease progresses, and we believe that in the last 12 months of life, we would like palliative care to become a greater focus and become 90% of the care plan and 10% of the care plan to be medical care. In other words, looking at the medications. And so palliative care really at the end stages of life is looking at managing the symptoms the patient is having.
Okay. So as you said, palliative care is a holistic approach. So we normally would go to a specialist. They would provide us with medication, but does palliative care also provide support for the family? Is there some aspect of palliative care for the family members as well?
Absolutely. So we believe that a patient comes from a family. So if it be yourself, you would have brothers and sisters, you may be a father, you may be a mother, and so therefore your illness has an immediate impact on your family. And one of the main aspects of palliative care really is once the diagnosis is confirmed, we would then request and ask the patient permission to actually discuss their illness with their family members. Because let's face it, who's going to care for that patient in their terminal phase of the illness?
It's the family members.
Absolutely. And therefore, the family members need to be aware as to what condition has led to this. And they need to be trained in certain aspects.
And how to manage the particular individual.
Absolutely. So it's not only about the medical management, but it's also about understanding what it feels like to be having a terminal illness. And when one has a terminal illness, one starts losing your independence. For example, an elderly patient who develops dementia. So they losing their memory, they may have Parkinson's or Alzheimer's dementia, and it may have been an accountant who was fantastic at running his business, driving his car, taking his kids to school, and as time goes on, he can no longer drive his car, and then he can no longer make his own decisions, and then he can no longer wash himself, he can no longer take himself to the bathroom, and in so doing the patient keeps losing their independence. And one of the things that palliative care needs to do is to explain to the family how that makes the individual patient feel. Because nobody likes losing their independence. And what palliative care tries to do is, if the patient can't do certain things physically, at least allow the patient to be able to make certain decisions for themselves. For example, where would they like to be in their last phase of life? Would they like to be in their home? Would they like to be in a hospital? Would they like to be in a hospice? And I can tell you that 90% of patients would love to be at home.
Okay, so what you're saying is palliative care is actually a support structure or an additional layer over and above the existing treatment that the particular person is receiving.
That's correct. So unfortunately, medical practice is complex. And for example, if a patient has a specific type of cancer, we as the medical practitioners first need to be able to confirm the diagnosis. And when we say cancer, there are thousands of different types of cancer. So the next step is determining what type of cancer it is, and every type of cancer has its own individual prognosis as well as its own individual management. But all of that is extremely complicated, and the oncologist or the cancer specialist is trying to do that bit as an expert to the best of their ability. And if we were to ask that oncologist to also include the palliative care approach, which really then means spending time having conversations with family members, breaking bad news, talking about the prognosis, and explaining the disease process and what the expectation is of the doctors, then that takes time. It takes at least 45 minutes to an hour to have that conversation.
So that's where the palliative care comes, the team comes in, correct?
That's right. So palliative care really involves a team. And the team members would include a palliative care physician, a doctor. It would include a palliative care nurse. It should include a social worker. There may be the need for a physiotherapist or occupational therapist. There is also the spiritual side. And every human being has a spiritual side to them. It may be their religious belief, or it may just be their spirituality. So being a doctor, our aim is to treat human beings, and therefore we are not allowed to actually have a prejudice. We need to be respectful of whatever the patient's belief system is, and to be able to understand that belief system and how the patient sees themselves. And therefore in my practice, we allow every patient to bring in their own spiritual leader or support. So whether it be the imam, it may be the minister, it may be their sangoma. And those patients should be supported in ensuring that spirituality is also taken care of.
Okay. So it's a sort of holistic approach besides the medication that the person is receiving. Can you maybe tell us a little bit about what is the difference between hospice and palliative care?
Right. So I would believe that palliative care is the umbrella, and hospice is part of palliative care. Now, in South Africa, everybody would know St. Luke's Hospice, especially in Cape Town. It is the cornerstone of palliative care and hospice care in South Africa. It was brought to South Africa by Dame Cicely Saunders, who was actually the founder of palliative care. She was first of all a social worker and then a nurse, and eventually became a doctor who developed palliative care at the time specifically for cancer. And so the hospice is generally a facility that provides a form of palliative care. For example, St. Luke's Hospice they've got 10 inpatient beds, and patients would be going to the hospice not necessarily to die there, but sometimes to go to the hospice for 2 weeks for what we call respite care. In other words, they are giving their family an opportunity to rest.
Okay.
Because caring for somebody in this situation of the stage of their disease is extremely taxing. It's emotionally draining. But not only that, often patients are not sleeping well, and when the patient doesn't sleep, the carer doesn't sleep. And so it can lead to carer fatigue.
Okay. Dr. Cupido, we've been speaking about palliative care. Can you maybe give the viewers one or two examples of your journey where you have actually been involved with patients up until the end of their life?
So, in the last few years, I've probably seen and walked this road with more than 1,500 patients. It's quite difficult to choose a specific case, but I'll give you an idea. So, a patient arrives at the hospital and has been in the healthcare system for the last 20 years, and they've developed chronic kidney disease, and the kidney disease really has been there for a while. But the doctor has told the patient, you've got chronic kidney disease stage 5, and because you're over the age of 65, you may not be a candidate for kidney transplant, and also that a kidney transplant wouldn't really change the outcome, especially when you've got diabetes and high blood pressure, because you've got other organs that have also been affected, and the patient may have had a previous heart attack or a previous stroke. But now the kidney disease is what's leading to their symptoms. And so the patient presents to the hospital and is now at the point where they're confused, their legs are swollen, and they have got severe nausea. And when we ask the family, do they know about the patient's condition, they say, no, we don't. Now, because of the doctor-patient confidentiality, before we can disclose any information to the family members, we need the permission of the patient. And that's a very difficult thing, especially when it comes to palliative care, because, as I said earlier, we want to include the family in the management and in the process of care. And what then happens is that the family says, but he's never told us. When he goes to the doctor, he comes home and he says, and we say, Daddy, what did the doctor say? And then the patient usually says, I've got some kidney problems. But they don't expand on the severity of the kidney disease. And so now suddenly it comes to the family as a shock that Daddy's now got end-stage kidney failure, is not a candidate for dialysis, and they have all these symptoms which are due to their kidney disease. And unlike a cancer, where you can see the patient gets a diagnosis, they've been on the chemo is not working, and over the next period of time, the patient gradually declines until their death. In a chronic disease, patients fluctuate. They have readmissions to hospital, and then they get better, and then they get worse. And it makes it almost more difficult, because most times the patient gets admitted to hospital and then they go home, which means that a perception is built that they're always going to come home. But one of those hospital admissions may lead to the death of the patient. And so it almost comes as a bigger shock. So very difficult for the family to deal with that, but we've become quite expert in this field in terms of counseling and providing the families with appropriate support. So yes, it's a very difficult, very emotional, both for us and the patient and the family.
Okay. Okay, that brings us to the end of the show. Before we conclude, is there any important points that you'd like to give the viewers?
Well, I think for the viewers, for them to know that palliative care is a right. Every patient has the right to die with dignity, and every patient has a right to have a pain-free death, and that if they do not feel as if they're getting enough support, then to go onto the Hospice Palliative Care Association of South Africa's website and find their nearest hospice to ask for help.
Dr. Cupido, it's been a pleasure having you on the show. Thank you very much for watching the Health Notebook. See you again next week, the same time, the same place.